guys. It is exactly 3 o'clock. Like I said, once I start sharing my screen, I may have to pause and let people in, but we have a lot to cover today. Okay. And as long as we're not talking over each other, I won't mute, but I'm going to go super fast. So I want to leave everybody unmuted so you can interrupt, ask the question, and we can move forward. So let's go ahead and dive into this.
Sounds great.
Okay, does everybody see AHIP Study Hall, Module 2?
Yes.
Yay, okay, let's go. So today on Module 2, we are going to learn about Part C and other Medicare health plans. And we're going to go super fast, so buckle up. Medicare Advantage. Under MA programs, also known as Part C, private health plans that cover all Part A and B benefits may also include Part D. They all have a maximum out of pocket for basic benefits, and many MA plans offer benefits Medicare does not. Coordinated care plans are plans that have a network of preferred providers and include HMO. Some have point of service, which allows members to go out of network with limitations. I added that with limitations. The carrier I worked for before I came over. Oh, we're echoing. That I worked for before we had a POS, and we learned the hard way that things such as chemotherapy with that particular carrier and mammograms were not allowed out of network, but basic services are. So I added with limitations because you really need to read if you're selling a point of service plan. Make sure you know what you're selling. PFFS is private fee for service. MSA is medical savings account plans, and special needs plans all include chronic special needs plans, dual special needs plans, institutionalized special needs plans, and I'm not sure what the other one means. MA eligibility must be entitled Part A and enrolled in Part B, must live in the Medicare Advantage service area. U.S. citizens are lawfully living in the U.S. on or before the effective date. CMS makes that determination. MA, MSA, special needs, employer group waiver plans have additional eligibility requirements. MA plans must enroll any eligible beneficiary regardless of health. In 2021, there used to be a restriction with end-stage renal disease. That was lifted in 2021. And there are certain special needs plans known as chronic special needs plans that limit enrollment to beneficiaries with certain condition. Generally speaking, C-SNPs focus on cardiovascular and diabetics, and there are others as well. Some MA plans charge a premium, and beneficiaries must generally continue paying for Part B in addition to their plan premiums. Cost sharing portion, member pays for services. There's deductible, copay, and coinsurance. MA plans have a maximum out-of-pocket limit for A and B benefits. Health plan pays 100% after a member reaches the specific MOOP. For 2025, the new maximum out-of-pocket limit for MA coordinated care plans and private fee-for-service plans is $9,350. The PPO out-of-network MOOP is capped at $14,000 for 2025. Remember, guys, CMS sets a maximum out-of-pocket, but different plans vary in their maximum out-of-pockets. So they can't go above the $9,350 or the $14,000 for out-of-network, but they may be lower. All MA plans must cover all of Part A and B benefits, and most MAs also cover original Medicare cost sharing for A and B benefits. MA plans offer special plans for those with certain chronic conditions, such as diabetes and heart failure, COPD, or other conditions. Health-related benefits for chronically ill may include decreased cost sharing and extra supplemental benefits. C-SNPs, the chronic plans basically make plans and tailor them towards the chronic illness that they are supporting. Special supplemental benefits for chronically ill may include food benefits, non-medical transportation, and pest control. MA plans may implement mechanisms to manage utilization of covered services. Such mechanisms include acquiring a referral or prior authorization to obtain services. PPOs may not require a prior auth for out-of-network services. Private fee-for-service plans may not require a prior auth, and non-network MSAs may not require prior authorizations. None of that was on the test. MA plans also implement step therapy. This is on the test, the step therapy for Part B or Part D drugs. When a plan requires the beneficiary to try a less expensive option before stepping up to drugs that cost more. So a lot of times that's going to be your generics before the name brand is approved. If you have a patient that you sign up that has been taking a name brand for many years, you can get the doctor to submit requests for the name brand with the carrier. When an enrollee enrolls in an MA plan after starting a course of treatment, there is a minimum of 90-day transition period. The MA plan may not disrupt or require reauthorization even if using an out-of-network provider for 90 days. So that really goes towards especially those who have cancer. They will not be required to move to an in-network provider for 90 days. Coordinated care plans, MA-HMO, must use doctors and hospitals within a defined network. HMO members may need to select an in-network PCP and require obtain a referral for specialists in some cases. A lot of the HMOs are not requiring referrals anymore to see a specialist as long as that specialist is in network. However, that specialist may require a referral and authorization before they will see somebody on HMO plan. If the type of specialist is not in their network, HMOs refer out of network. Point of service, POS, members may seek some treatments out of network, unlike HMO. Unlike a PPO, HMO POS may limit available services or put a dollar cap on the out-of-network services with higher cost shares. I think this is just me talking, and I know we're being recorded, but I think point of service plans still have a lot of work to do. I'm curious how they look this year. Not behind the POS, just so y'all know, is some of the markets, especially rural markets, that don't have great network adequacy, meaning that they don't have a lot of in-network providers and services have a POS. But again, it's so limited. I think there's a lot of work to be done there. MA coordinated care plans, PPO, can get care from any provider in the U.S. who accepts Medicare. That is on the test. Coordinated care, PPO, can get care from any provider in the U.S. who accepts Medicare. No referrals are needed to see out-of-network providers with higher cost shares. Regional PPOs are offered throughout an entire region comprising of one or more states. Special needs plans, PPO and HMO, specially designed to serve a subset Medicare population. In addition to meeting all other MA criteria, they also must meet criteria specific to the type of special needs plans. All special needs plans include Part D. That is also on the test. These are only available to beneficiaries with certain chronic disabling chronic conditions such as diabetes, heart failure, cancer, lung conditions, HIV, and other certain conditions. It repeats itself so much. Each C-SNP will specify the conditions necessary to enroll. Dual special needs plans, known as D-SNPs, for beneficiaries with Medicare and Medicaid. Fully integrated dual eligibles, FIDE, special needs plans provide enrollees access to Medicare and Medicaid benefits under a single managed care organization. All you need to know for the test is that D-SNPs provide enrollees access to Medicare and Medicaid benefits under a single managed care organization. Institutional special needs I-SNPs are for MA eligible who for 90 days or longer have or need services provided in long-term care, special skilled nursing facilities, intermediate care for intellectual and developmental disabilities, long-term care hospital, inpatient psychiatric facility, or other facilities defined by CMS. Institutional equivalent special needs plans, MA eligible who live in a community but require institutional level of care, i.e. special needs plans may limit those in assisted living facilities. That's all you need to know is that it is used, i.e. institutional equivalent special needs plans may limit those in assisted living facilities. The model of care for special needs plan, CMS approved plan for coordinating care and providing services in its members. Special need plans must conduct a comprehensive initial health risk assessment of each enrollee, physical, mental, and functional needs, as well as any annual health risk reassessment. Special need plans manage the care of their members using interdisciplinary team. IDT, it's on the final, not the module test, including providers with expertise in training and treating individuals similar with targeted population of plan. Special need plans must develop and implement a comprehensive individualized plan of care through the IDT, identifying goals and objectives, including measurements, outcomes, and specific services and benefits. I will send this out to everybody, by the way. Those enrolled in a private fee-for-service may receive services from any provider in the U.S. that is on the test, eligible to provide the care, accept the terms and conditions of the plan, and accept payment, not limited to a network. This first bullet point is on the test and the final. Some private fee-for-services contracts with network providers. If there's defined network and a member goes out of network, they may have to pay more. Except in emergencies, members must inform providers before receiving services that they have a PFFS, which is private fee-for-service, so the non-network providers can decide if they want to accept the plan's terms and conditions. Non-network providers that accept Medicare may not decide to take the PFFS. That is on the test. Therefore, enrollees must confirm that their provider will accept a private fee-for-service plan before enrolling. Providers cannot charge more than outlined in the plan's terms and condition. Cost sharing may include a balance billing of 15%. That is the second question concerning this. Remember, private fee-for-service, 15% balance billing of the Medicare rate, but only if outlined in the plan's terms and conditions. This happens when the provider is eligible to accept Medicare, but not a Medicare participating provider under original Medicare. Private fee-for-service plans can choose whether or not to allow balance billing, and the plans may or may not have Part D. That means that they may enroll in a standalone Part D drug plan if they choose. Medicare savings account. There weren't a lot of questions about this in years past. I've gotten hung up on a lot of these questions because just in the general terms of where I am, we do not see a lot of Medicare savings account plans, but I did not notice a lot of questions regarding this. MSAs are high deductible health plan that is combined with a savings account. Medicare contributes to their savings account. That question, there was a question about who contributes to the savings account. It is Medicare. Medicare contributes money to the Medicare savings account to help pay for Medicare covered services during the deductible phase. Money left in the account remains, and Medicare will add any new deposits. If the beneficiary uses all the funds in their account, they must pay out of pocket until they reach their deductible. After the deductible is met, the plan pays 100% for covered services. Max deductible was $16,000 for 2024. That I have not seen any new ones. However, most have a much lower deductible. MSAs do not include Part D, and you must enroll in a standalone PDP. Enrollees pay Part B as well as premium for the supplemental benefits. They can receive covered services any Medicare approved provider in the US if the provider decides to accept their plan. MSAs may have no network, full network, or partial network. Non-network providers must accept the same amount as original Medicare's payment in full. This is how the member pays until the deductible is met. There is no premium for MSA. MSA plans cover Part A and B benefits, and beneficiaries continue to pay their Part B premiums. Ooh, that was a mouthful. Those who are not eligible for MSA, those who receive health benefits that cover all or part of their annual deductible, those who are enrolled in FEHB or eligible for VA benefits. FEHB is Federal Employee Health Benefits. Dual eligible are not allowed to enroll those who do not reside in the U.S. for at least 183 days of the effective year, and those on hospice. MA employer union plans. There weren't that many questions about this either. Employers and unions may offer their retirees and dependents MA individual plans open to the public. MA plans only available through the employer, which is known as Employer Group Waiver Plans, EGWPs. Direct contract plans, MA contract between employer and CMS. Whew. Direct contract plans are different than other MA plans. Eligibility to enroll is limited to certain active employees, retirees, and their dependents, because various regulatory requirements are waived as they apply to the plans. Any size employer group can offer MA to their retirees. That's important to know. Employers less than 20 may be able to offer MA plans to their active employees and dependents. That is one of the questions on the test. Active employees must maintain their non-Medicare group health because Medicare is secondary. This means that Medicare will only pay for services that are not covered by the primary insurance. This follows Medicare secondary payer rules. That is employers with less than 20. Any questions so far? Okay. Medicare coordinated with employer group health plans. Rules for Medicare eligible employees and whether Medicare group coverage pays first. Large group health plans, GHPs, have 20 or more employees. There was not one single-dairy question on my test for this. That doesn't mean there won't be one on yours. Have 20 or more employees, or if they are covered under a spouse's large group plan, Medicare is primary. So what that is saying is beneficiaries who large group health plans that have 20 or more employees, or if a beneficiary is covered under a spouse's large group plan, Medicare is primary. It is legal for large group health for large groups to encourage a Medicare beneficiary to decline employer group coverage or offer different coverage. This includes offering the employee or spouse a Medicare Advantage or supplement. Small group health plans, Medicare is primary. GHPs do not have to offer the same plan for those 65 plus and can offer to purchase MA or Medigap. That is small group. So large group, they cannot. Small group, they can. All these acronyms. Employer group waiver plans, also known as direct contract plans, only available to active employees who are Medicare eligible or retirees of the employer or union. You're going to see this a lot in like schools, state, places like that. Enrollment in EGWP must be based upon employment-based health coverage from employer union group health sponsor. Example, an association of employers such as school boards can offer former employees an employer group waiver plan for purposes of offering retirees health coverage. A professional association may not, because membership is based on a profession, not a former employer. Beneficiaries who qualify for Medicare and Medicaid are dual eligible, enrolled in Part A and or B, receiving full Medicaid benefits and or assistance with Medicare premiums or cost sharing. Medicaid helps pay for premiums, and cost shares are also known as Medicare savings programs, not to be confused with the MSA, Medicare savings accounts. QMB is Qualified Medicare Beneficiary Program, helps pay premiums, deductibles, and copays for A and or B. SLMB is Specified Low Income Medicare Beneficiary Program, helps pay for Part B premiums. QI is Qualifying Individual Program, helps pay Part B premiums. And you'll see all these acronyms when you're looking through plans that are designed for LIS and dual eligibles. QDWI is Qualified Disabled Working Individual Program, pays Part A premium for certain disabled and working beneficiaries. QMBS's special rule apply for QMBs, enroll in any MA plan. Did anybody hear that duals can enroll monthly starting in 25? Today it's quarterly. Starting in 25, they will have a monthly option to enroll into a D-SNP plan. So not a plan that coordinates with Medicaid, but an actual dual special needs plan monthly. When a QMB enrolls in their MA plan, the beneficiary does not have to pay more cost sharing than any minimal copayment that would apply under Medicaid. All providers, whether or not they are Medicaid participating or in network, are prohibited by law from balance billing duals for any Medicare cost sharing amounts. Providers who balance bill are subject to sanctions. Now, this could be that one of your clients who's a D-SNP may receive a bill in the mail and it may be by error, so I wouldn't just start rushing to say that they're going to get sanctioned, but it is definitely something they may need help with the carrier. QMB only beneficiaries who just receive assistance paying for their Medicare premiums and cost sharing. QMB plus beneficiaries who are also eligible for full Medicaid. Dual eligible beneficiaries can enroll in any type of MA plan except for MA, MSA, and D-SNPs are tailored to dual eligible, whether they're eligible to medical benefits under Medicaid but not Medicare. Medicaid may provide additional items and services as covered benefits, but will only pay for them if furnished by participating providers. If a provider is not participating in Medicaid, must hold beneficiary harmless. My gosh, how many D-SNPs are there? How many more slides do we have? There were 35 slides to this, and we're in 27, and then we'll move over to module 3. How much time do we have? Okay, we're doing good. FIDE D-SNPs, fully integrated dual eligible, provides duals coordinated access to Medicare and Medicaid benefits, including primary care, long-term services, and support under a single organization that has an MA and Medicaid managed contract. HIDE D-SNPs, HIDE, are highly integrated dual eligibles, and they cover long-term services and support or behavioral health services under a capitated contract between Medicaid and an MA organization. And coordinated only D-SNPs are not fully integrated or HIDE. Generally, there are obligations to notify the state Medicaid agency of hospital and skilled nursing facility admissions for certain high-risk full benefit duals. A lot of this is not on the test. MA plans must offer at least one plan with drug coverage in any service area. Beneficiaries can only have drug coverage through the MA plan. If they enroll in an MA plan without drug coverage, they cannot enroll in a PDP. That question is on the test. Certain employer union retiree groups may have other options. MA, private fee-for-service, have an option to offer prescription, but not required to. That is on the test. Beneficiary enrolled in MAPFS that does not have Part D coverage may enroll in a PDP even under the same MA contract. Let me repeat that because that question too, they're trying to confuse you, is on the test. A beneficiary who enrolled in an MA private fee-for-service that does not have Part D coverage may enroll in a PDP even under the same carrier. MSAs are prohibited from offering prescription coverage. Beneficiaries will have to enroll in a standalone PDP. Other types of medical health plans, cost plans, Medicare health plans that are not MA plans nor Part C and are not original Medicare. That is on the test. They ask it a little bit differently, but just know that cost plans are Medicare health plans that are not MA nor Part C and are not original Medicare. May offer Part D as an optional benefit, not required. May offer additional supplemental benefits, only available in certain areas. The same stay true for 25 as in 24. They are offered in select counties in, sorry, I had another hiccup, in Kansas, Minnesota, North Dakota, South Dakota, Illinois, Wisconsin, Iowa, Missouri, Oklahoma, Wyoming, and Nebraska. I can tell you for certain that we do not sell a lot in Oklahoma. Beneficiaries can enroll in a cost plan and PDP regardless if the plan offers Part D coverage. Enrollees may choose to receive their Medicare coverage services from a plan network provider. Plan cost sharing applies. Under original Medicare, non-network providers, original Medicare cost sharing applies and is usually higher than those through cost. For full benefits, you must have A and B, or those with only B will not have Part A coverage. That is on the test. Cost plans for full benefits must have A and B, or those with only Part B will not have Part A coverage under the plan, and premiums may be adjusted. Any questions? Okay, moving on. PACE is Medicare plans for frail and elderly beneficiaries living in the community, available in most states with small service areas. Offer adult daycare, includes comprehensive medical and social service using an interdisciplinary team approach in the adult day health center, supplemented by in-home and referral services. Must be 55 and plus, reside in the service area, certified eligible for nursing home care, but not able to safely live in a community at enrollment. Why am I getting crossways on these? I think I'm reading too much. And that is on the test. Must be 55 plus, reside in service area, certified for eligible nursing home care, but able to live safely in a community at enrollment. There are no deductibles or copays for any drug services or care approved by the PACE team of the healthcare professionals. Beneficiaries with Medicare pay only a monthly premium to cover the long-term care portion of the PACE benefit and Part B and D premiums. Those with Medicaid pay no premiums. Medicare Medicaid plans, known as MMPs, established under demonstration authority, only available in certain counties of Rhode Island, South Carolina, Texas, California, Illinois, Massachusetts, New York, and Ohio. That is not on the test. Unlike D-SNPs, MMPs financially integrate and provide Medicare Medicaid benefits. All MMPs offer Part D coverage and are not MA plans. All MMPs include Part D benefit. Enrollee protections, appeals, and grievances. MA cost PACE or MMP plan enrollees have the right to file complaints, grievances, including the complaints about quality of care. I will tell you on the test, you only need to know the difference between grievances and appeals. That's the only thing it's asking. get decisions about healthcare payment or services or prescription drug coverage, get a review, appeal a specific decision about payment, coverage of services, or prescription drug coverage. The test is going to ask about grievances on the one I took. Yours may ask about appeal. Filed if the beneficiary experiences problems with healthcare services such as timeliness. That is specifically the question on the test. Appropriateness, access to and or setting of provided health services, procedure, or item. May also include complaints that covered health service, procedure, or item furnished did not meet acceptable standards for the delivery of healthcare. Enrollee or representative can make the complaint orally, in writing, or through CMS website. That is also on the test. Plans must provide a link to Medicare.gov where they may enter a complaint. That is also on the test under grievances. Determinations made by Medicare health plan, whether medical care or prescription are covered, how they are covered, and cost share. An enrollee has the right to ask for a prior authorization, even if it is not required, to find out if a service will be covered. That never happens. Appeals. If an enrollee or a physician is unsatisfied with the coverage decision, it is a formal way to ask the plan to review or change a coverage decision. An appeal can be filed if the health plan did not pay for an authorized service that should have been covered. The enrollee must be financially liable to file an appeal. Believes an authorization service is ending too soon. This is on the test. It is an appeal if they feel like a service is ending too soon, such as home health or hospitalization. Believes the plan is not authorized or paid for Part D drug that should have been covered. Medicare health plans must provide members with written description of the appeal process. Part D must provide access. This is on the test. Part D must provide access via secure website or email address on the website for quick requests and determinations of appeals, and require network pharmacies to provide. This is also, this specific part right here is on the test, that and require network pharmacies to provide a printed notice, including the plan's toll-free number and website, to request a coverage determination. That is on the test, both the module test and the final. Okay, I'm going to stop sharing so we can switch over. Any questions on module 2 as I flip us over to module 3 really quickly? Okay, guys, I am going to be brutally honest with you. This next module sucks. It's hard. It's a lot. It's hard to
don't sugarcoat it.
Oh, feel free to interrupt. 25 is bringing a lot of changes in this module. So buckle up. Here we go. Don't worry, we're fixing to share. It's just got to get there. Okay. I'm going to take a sip of my water, and then we're going to get going. So I'm going to talk really fast and really in depth. All right, guys, here we go. We're just going to jump right into it. Overview changes in 2025. The Inflation Reduction Act, a significant legislative development, has prompted Congress to make several changes to the Part D program, which will be implemented in 2025. Eliminating the coverage gap from the standard Part D benefit structure, capping beneficiary out-of-pocket costs at $2,000 for Part D. So what that's saying is that their copays and the expense from the beneficiary will not be more than $2,000 for any and all Part D drugs throughout the entire year of 2025. Adding a new program, the Medicare Prescription Payment Plan, which provides beneficiaries with the option to pay their out-of-pocket Part D prescription drug costs in monthly amounts over the year instead at the point of sale. This legislation also imposed specific requirements on drug manufacturers that may reduce the cost of Part D drugs. So they're saying that because a lot of the Part C and D plans went to CMS and said, great, I'm glad that we've capped it at $2,000 for the patient, but that's going to be reflecting in our deductible amounts, our premium amounts, and, benefits in the MAPD plan. So it gets interesting. Buckle up. Part D covers certain prescription diabetic supplies and vaccines. Part D is only covered through private companies, must be entitled to Part A and or enrolled in Part B, not enrolled in Part B for immunosuppressive drugs. A U.S. citizen or lawfully present in the U.S. on or before the enrollment effective date, CMS makes the determination, as we heard before. There is not a fee-for-service Part D benefit. PDP stands for standalone prescription drugs. Cost PD plans cover Part D prescription drugs as an optional benefit. Medicare is Medicaid and PACE plans. Eligibility to enroll in a PDP depends on how they receive their medical benefits. MA/MSA members may only have Part D through a PDP. That is on the test. Cost plan or MA/PFFS, private fee-for-service plans, can select an offering with Part D if available or enroll in a standalone Part D prescription drug plan. That is on the test. MA/HMO PPO may only obtain Part D coverage inside the plan. Medicare, Medicaid, or PACE may only receive Part D through their plan. Part D covers prescription drugs, biologics, insulin, medical supplies used to inject insulin, syringes, needles, alcohol wipes, or delivering insulin into the body. Certain vaccines not covered by Part B, such as shingles vaccine and Tdap, are Part D. Non-covered Part D drugs. The following are excluded from Part D. Weight loss or gain, fertility. I cannot imagine, I'm in my 40s, but I cannot imagine somebody, I'm just going to leave that one there. Weight loss or gain, fertility, cosmetic drugs, symptomatic relief of cough and colds, vitamins, medical foods, erectile dysfunction for purposes of sexual dysfunction. I want to touch on that because there are heart medications that are also used for erectile dysfunction. And so you may, if somebody is on one of those, it may be for purposes of a heart condition. Non-prescription drugs, some off-label use, drugs covered under Parts A and B, and Part D plans are allowed to offer additional drug benefits excluded from offering weight loss prescription drugs. So some off-label use, what that means is there are prescriptions that people use for other purposes than what the FDA has intended them for. Some people are using like Ozempic? Yes. I was trying to be nice. Okay. Oops. I went around the whole world for that explanation. To not be controversial. Yes, Ozempic. That's one of them. Formularies. Part D plans list drugs they cover in a formulary. Formularies are developed by pharmacists, doctors, and other experts. Believe it or not, that is on the test. That is on the final. It was on one of mine. The next Part 2 was also, Part D formularies must include at least 2 drugs in each therapeutic category. That is on the test as well, generic and name brand. Tiering. Part D benefit structures and formularies create cost-sharing tiers. Guys, it is going to be so important to go over your clients list or anybody who calls in with their prescriptions, because their tiering may change on the PDP or MAPD due to the Inflation Reduction Act. So tier 1's generic, tier 2's preferred name brand, tier 3 non-preferred, tier 4 is high cost drugs or specialty drugs, and carriers may have additional tiering, which most do. When evaluating whether a Part D plan should be recommended, it is important to confirm that the drugs are on formulary and evaluate the cost sharing tier they fall into. Super important, guys. Standard and alternative Part D benefits. Alternative benefits, benefit structures that are not standard, but instead are actuarially equivalent. This means the value of the Part D benefits must be the same as of at least standard coverage. Standard coverage is outlined by Medicare CMS. Enhance alternative benefits for additional premium may reduce the deductible, cover excluded drugs, and or decrease coinsurance amounts. Standard benefit includes several coverage phases, which does not even apply to this year, because you can have a deductible and then you go through it, but we don't have the gap anymore. True out-of-pocket costs. True out-of-pocket costs that count towards the annual out-of-pocket threshold to move into catastrophic coverage phase. Calculated on an annual basis, generally includes, there were a lot of troop questions, guys, just so you know, generally includes beneficiary payments for Part D drugs, including the annual deductible, cost sharing above the deductible, and up to initial coverage limit and beyond. After the initial coverage period, a drug manufacturer's discount counts towards the troop. Generally, for drug costs count towards troop, drugs must be on formulary and purchased at a network pharmacy. That's the question that's on the test. You just need to make sure they're on formulary and purchased through a network pharmacy. Amounts paid for some by the AIDS Drug Assistance Program and Indian Health Services count towards troop. Amounts paid through qualified state pharmaceutical assistance programs, most charities, also count towards troop. Excluded, drugs not on formulary unless there is an exception, over-the-counter, non-Part D drugs, and Part D drugs obtained out of network unless a Part D policy applies. More troop excluded. Continued are costs paid for or reimbursed to an enrollee by insurance, group health, most government-funded health programs, or another third party, including Medicaid CHIP, federally qualified health centers, TRICARE, FEHB, and the list goes on. It's not on the test. Part D coverage is generally provided through contracted pharmacies, network pharmacies in their service area, except for that PFFS plans that are not required to use a pharmacy network but may choose to have one. Plans may designate preferred pharmacies that offer lower cost sharing versus standard cost sharing. So what they're saying is a standard pharmacy is not out of network. They just may have higher cost shares. Certain circumstances may allow to fill prescriptions out of network covered in troop. That's going to be like when they're traveling or circumstances result in limited drug access through a network pharmacy. The test is going to ask about traveling and getting a refill. Part D plans usually charge a premium. Yes, they do change a lot. Typically, higher premium means lower out-of-pocket costs. Part D enrollees have 3 options for paying Part D premium: electronic monthly premium payments, direct billing from the plan, auto deduction from Social Security. They're really trying to get people away from that. But the answer to the question is you should use one mechanism of paying your premium throughout the year and not change it. That's the answer to the question. Generally, beneficiaries must stay, there it is, stay in the same premium payment option for the entire year. If no option is chosen, they will be billed by the plan. Beneficiaries may have to pay a monthly premium penalty to join a Part D plan. They do not have credible coverage and do not enroll when first eligible. If there has been 63 continuous days following a beneficiary's IEP and did not have a Part D or continuous coverage. 63 days, 1%. That's what you need to know about the Part D LEP. Penalty is in effect as long as the beneficiary has Medicare prescription drug coverage. Those who qualify for LIS will not have a LEP. That is also on the test. So 1%, 63 continuous days following initial enrollment period, and if they have LIS, they will not have an LEP. Part D, tools and formulary requirements. Step therapy, one or more similar lower cost drugs may be tiered before expensive drugs are covered. Prior auth requires the doctor to contact the plan and request authorizations before the drug will be covered. That is especially if somebody moves to a new plan that has been on a name brand drug, and then they come in and the carrier saying, hey, wait a minute, let's try this generic, and they've already failed at that, the doctor can send in a prior authorization. Substitution plans may substitute generic for name brand drugs if generics have the same or lower cost sharing and certain conditions are met. CARA can set limitations if they feel a drug may be misused or abused. Is everybody familiar with CARA? That was put in place for people abusing opioids. Enrollees initially enrolling in Part D switching plans and current enrollees affected by the formulary changes must receive at least 1 month fill of their non-formulary drug during the first 90 days after enrollment, plan switch, or formulary change. If an enrollee in a long-term care setting is outside of their 90-day transition period, the plan must still provide 1 month supply of non-formulary Part D drugs while an exception or prior auth is being processed. During the transition period, the plan does not apply prior auth or step therapy rules. Requests by the enrollee and physician for an exception to continue the drug or transition to formulary drug. It's not on the test. Requesting coverage determination and appealing decision. Part D plan sponsors must give access via secure website or secure email on website for enrollees to quickly to request a determination whether a drug, I've been reading too much, I'm getting tongue-tied, whether the drug will be covered or appeal a decision. Enrollees may appeal coverage determinations, decisions on exceptions, or request tiering of formularies. Plans must also require network pharmacies to provide a printed notice with the plan's toll-free number, website to request coverage determination. LIS is low-income subsidy, covers all or part of Part D premiums and cost sharing. That should not say 22, it should be 25. Because everything went up, and I have a whole thing, but those with limited income resources should be encouraged to apply for LIS through the Medicaid office and Social Security Administration. They can apply anytime after approval is effective the first day of the month in which they applied. Automatically qualify for extra help is full Medicaid, help from the state Medicaid program, paying their Part B premiums, and Medicare savings programs. They get supplemental Social Security income benefits, and Medicare mails them a purple letter to let them know they automatically qualified. So when you're talking to somebody to see if they qualified, ask if Medicare sent them a purple letter. I'm going to skip through a little bit because we're due to time. There's a lot of this repeats itself. Okay. Let me see if there's anything else I missed sharing with you all for 2025. Any questions while I'm looking? I'm going to pull up. I'm going to escape. I'm going to give y'all a pop quiz because we have a couple of minutes on module 3. It's opening. Okay. True or false? The Medicare, this is new, the Medicare prescription payment plan helps spread out beneficiary cost sharing payments, but does not decrease the total amount owed. True or false?
True.
Very
True.
good. Very good. Okay. Let's see how I'm going to word this one. True or false? Formulary exception requests cannot be used to request coverage of a drug on a Part D plan's formulary or to cover a formulary drug at a lower cost formulary tier. True or false?
True.
False.
False. Formulary exception requests can be used to request coverage of a drug not on a Part D plan's formulary or to cover a formulary drug at a lower formulary tier. Let's see here. True or false? Everyone who is entitled to Part A or enrolled under Part B is eligible to enroll in a Medicare prescription drug plan.
True.
True. He must be eligible for Part A and or enrolled in Part B to get a standalone prescription drug plan. Okay. Let's see here. Oh, here's the question. True or false? Generally, a Part D beneficiary must stay with the premium payment option for the entire plan year. True or false?
True.
True or false? Yes. True or false? Part D
True.
formularies must include at least 2 drugs in each therapeutic category, whether or not generic versions are available.
True.
True.
Well, that's tricky.
That is. It's tricky, but it's true.
Okay.
How are we going to word this one? I'm just going to tell it to you. This is the question about Ms. Roswell when you get to this. Ms. Roswell is a new enrollee. Those initially enrolling in Part D, those switching plans, and current enrollees affected by formulary changes must receive coverage of a single 1-month fill of their non-formulary drugs. So what they're talking about is when somebody comes on to a plan that they are allowed 1 month of their prescription drugs while they're seeking approval with the carrier and their doctor for the off-formulary drug. Okay, here's one that we did not go over. This is going to trick you. True or false? I can't believe I got this one right because I didn't read one thing on it. Part D enrollees can opt into the Medicare prescription payment plan at the beginning of the plan year or any point during the year. True or false?
True. Guessing.
Yep, it's true. It's true. So at any point they can do that. Obviously, the amount that they owe will be higher, the less months that they have to spread it throughout. Okay, here's the question. Tell me how tricky this one is. Mr. and Mrs. Vaughn both take a specialized multivitamin prescription each day. Mr. Vaughn takes a prescription to help regrow his hair. They are anxious to have their Medicare prescription drug plan cover these drugs. What should you tell them? I'm curious, what would you all tell them?
Not covered.
That they're not covered.
The
Their
drugs the Vaughns are
prescriptions.
interested in may be covered as a supplemental benefit. Yes, they are not covered traditionally.
How would that be, like an OTC kind of thing for the
Yes.
vitamins? Okay.
I
good.
think so.
But the question said they were prescriptions.
Yep, I know. And I guess they're saying that some plans may decide to elect to cover them. I'm telling you, that is a tricky question. But the answer, the correct answer is Medicare prescription drug plans are not permitted to cover the prescription medications the Vaughns are interested in under Part D coverage. However, plans may cover them as supplemental benefits, and the Vaughns could look into that possibility. That is the correct answer. Tricky, huh?
Yes.
Okay. This one is in regard to cost plans. Ms. Lopez is enrolled in a cost plan for her Medicare benefits. She has recently lost credible coverage previously available through her husband's employer. She is interested in enrolling in a Medicare Part D prescription drug plan. What should you tell her? Should you tell her that if a Part D benefit is offered through her plan, she must enroll in this plan? Or is the answer, if a Part D benefit is offered through her plan, she may choose to enroll in that plan or a standalone PDP?
B.
This is cost.
B.
Yes, correct. If Ms. Lopez is enrolled in a cost plan, this provides her with options as how she secures Part D benefits. Beneficiaries enrolled in a cost plan may obtain Part D benefits through their plan if offered, or through a standalone prescription drug plan. Let me wait 3 minutes. We'll do one more question. Let me find the trickiest one. Cheat sheet in front of me where I took the test. Okay. Mr. Bickford did not quite qualify for extra help under the Medicare Part D prescription drug program, and he is wondering if there is any other option he has for obtaining help with his considerable drug costs. What should you tell him? Should you tell him he could check with the manufacturers of his medications, or that he should contact his neighbors and family and ask them for help? Should he go and ask his family and friends for help, or go to the manufacturer?
Manufacturer.
Correct. And that one was tricky because a lot of times when you look at manufacturer coupons for drugs, it'll say, if you have Medicare, we will not offer you manufacturer coupon.
Right.
But it's on the test. That is the answer. So that's why I wanted to share that one with you. Okay. All right, guys. Our time is coming to an end, and I do have a hard stop. If anybody needs any help, feel free to reach out to me, call me, email me, whatever you need to do. Everybody who attended, I will email, hopefully by end of day. I'm pretty jam-packed, or it'll be in the morning. I will get these module 2 and 3 slide decks to you so that you have them to take your test.
Awesome. Thank you, Taryn.
You're
Thank you.
welcome.
Thank you.
You're welcome. Bye, guys.
Bye.
Bye.